Swati. Thank you, Lubna. I would like to begin by acknowledging that we live and work on the traditional territories of many Indigenous nations across Turtle Island. While we meet today on a virtual platform, we must recognize the importance of the land and our treaty agreements. We acknowledge the ancestral and unceded territories of all Inuit, Métis, and First Nations peoples. As our Spinal Cord Injury Ontario community encompasses many geographies, we ask that everyone take a few minutes of their day to find out which unceded or treated territories you may live and work on. You can use the link www.native-land.ca to learn more. And Lubna will put that in the chat box. So again, welcome everyone. My name is Julie. I am a peer program coordinator in the London region. My co-host today is Lubna, who is the manager of our peer program. So we are recording this session, and we are going to do a question and answer period at the end. So we will stop the recording when the question and answer period begins, so that way you can feel free to ask your questions and it won't be recorded. We will mute you or mute everyone throughout the presentation just to cut back on the background noise. There is the chat feature as well, so you're more than welcome to write down any questions you have throughout the presentation in the chat box, and we can get to those at the end as well. Okay, so with a grant secured from Craig H. Nielsen Foundation, Spinal Cord Injury Ontario has developed a series of 6 e-learning courses on aging with a spinal cord injury. You can access these courses by going to cordtree.com and clicking on the Disability Education Center tab. So today we are going to be talking about aging and mental health. So we've got 2 guest presenters. Swati Mehta is a research scientist at Parkwood Institute Research, St. Joe's Healthcare, London, Ontario, and an adjunct assistant professor in the Department of Physical Medicine and Rehabilitation at Western University. Swati holds a Master's of Counseling Psychology. She is a registered psychotherapist and a Canadian certified counselor. Swati's research explores improving access to comprehensive mental health services for people with spinal cord injury to improve their emotional well-being. We also have Wallace Upper, who is here to share his experience. Wallace has sustained a T6 complete spinal cord injury in 1988. He has a master's degree in social work and is currently working as a clinical research associate with Rehab Psych Lab at Lawson Health Research Institute. Sorry, I lost my page again. Here he provides clinical support to persons with neurological conditions through the online mental health services offered. So I will now let Swati and Wallace start the presentation.
Thanks, Julie. Hope everyone can hear me. I'm just going to share my screen. Just want to confirm everyone can see my screen. Yeah, okay. So I just want to talk to you guys a little bit about aging and mental health after spinal cord injury. As Julie mentioned, my name is Swati Mehta, and I'm going to be joined here today with Wallace or Randy Upper. And basically what happens is individuals with spinal cord injury have been shown to have a greater likelihood of experiencing psychological distress compared to the general population. And this is really important because psychological distress can really impede the rehabilitation process. High levels of depression have been correlated with decreased functional improvements and independence, greater levels of pain, and increased hospital stays. And psychological distress can really interfere with people's ability to socialize and carry out everyday activities. And as people age with a spinal cord injury, they may start to experience accelerated deterioration in their functional capacity, and this can really impact their mental health. And so when we're learning to self-manage our symptoms, it's really important to have more of a multimodal approach. And to give you an idea of why using multimodal approaches is really important, imagine that you work all day hunched over a computer and you start to develop chronic neck pain. You can start taking medication for this, like anti-inflammatories, and this really works great to keep you from using it. But when you really start to use it, you can start to feel helpless and unmotivated. And some of the things you aren't able to fix in this situation, right? So you may want to start to get maybe an occupational therapist to help you set up your desk so that it gives you better posture. You may want to work with a physiotherapist to learn different stretches and exercises you can do to improve your neck strength. But also you can use these strategies to get motivation and self-confidence in your abilities to self-manage those symptoms. And that's where working with a psychotherapist or a counselor can really help you. So you can really learn different strategies on changing your behaviors and your thoughts and keeping yourself motivated to engage in healthy behaviors so that you can maintain a healthy lifestyle. And so when we develop these modules, we wanted to raise awareness of how mental health concerns can really arise amongst people aging with spinal cord injury. And we wanted to make sure that we weren't just concentrating on the mental health of people that are older, but instead we wanted to concentrate and share experiences of people as they age with a spinal cord injury. And so we really tried to incorporate concerns from people with different stages in life and how aging process can really affect people. And so the module on aging with a spinal cord injury and mental health through CoreTree really kind of provides a brief overview of why mental health is important, talks a little bit about some of the common myths and concerns people might face, and some basic skills you can use to manage your mental health. And I think the most integral component of the module is actually the peer stories. And we were really fortunate enough to have individuals with diverse backgrounds to show how mental health has affected them as they aged with their spinal cord injury. And so I'm just going to take a minute to kind of let you guys listen to Oda's story about how mental health has affected him.
I have a complete spinal cord injury at the C6 level. After my injury, I experienced a lot of depression and issues with my body image. I felt isolated in my body as well as socially. As I grew older, I was able to overcome these obstacles by first and foremost accepting myself using mindfulness and meditation. Knowing myself and self-compassion were instrumental in this acceptance of myself. Once I was able to accept my inner self, I was able to explore my outer self. My self-image was not healthy. The most important change was becoming more active and social. Activity improved my mental and physical health. Playing sports like wheelchair basketball and rugby made me feel better about myself, my body, and my abilities. This also gave me things to look forward to and a schedule to keep. These things helped me be happier with myself and the life that I am living.
And so you can see from Oda's story, there's different aspects of mental health that affected him and ways that he kind of overcome some of those issues. And so now what I'm going to do is I'm going to switch a little bit of the gears and talk a little bit about some common myths that people might experience. And some of these include things like, because I've had a spinal cord injury, of course I'm depressed. And that's a myth that a lot of people might have. And it's not always the case because yes, you might have, a grieving process after an injury, but there's lots of people that adapt well to their injury and live very fulfilling lives. So that's a very big common myth that people experience. Another one is, everyone gets depressed as they get older, and that's just part of the aging process. And I think I see that even in individuals that are seniors and don't have a disability. And unfortunately, that's not, again, the case. There's lots of ways that we can still be involved and have a self-concept and play important aspects of society that can help us be living fulfilling lives. Another common myth is having the idea that a mental health illness is not really an illness and only physical disability is an illness. But I think, as many of you may have experienced, mental health can also impact you functionally and be able to kind of not allow you to participate in different activities and different livings. And so you can see how mental health is also an important condition to kind of target and seek treatment for. And lastly, people who experience mental illnesses are weak and can't handle stress. And again, just because you've had a mental health illness doesn't mean that you're weak. Maybe there's just so many things going on in your life that you're not able to cope properly, or maybe you don't have the skills that you need to cope with the stresses that you have. And so it doesn't really relate to your weakness. It just relates to the need for some support. And hopefully you can reach out and get those supports going. And so what we're going to do today is kind of give you some options on where you can seek those supports. So one of the things that our program, the module, was based on was this idea of cognitive behavioral therapy. And this type of psychotherapy really involves empowering individuals to help self-manage their overall well-being. And it really helps you to focus on understanding your thought process and how those thoughts can really influence what we do and how we feel. And so if you remember, I mentioned CBT really has to do with how thoughts, feelings, and behavior interact and influence each other. So let's take a look at an example of pain and how these three interact with each other. One thought many people have when they have chronic pain is that their pain is never going to go away. It's never going to get better. And when we have this thought, they might stop seeking treatments. They might just kind of give up and feel like they don't have anything that'll work. So there's no point in trying. And so having that behavior, that unhelpful behavior, can lead us to have feelings of hopelessness and sadness. And so you could really start to see how this really creates this vicious cycle of unhelpful thoughts where you feel your pain's never going to go away, it's never going to get better, and unhelpful behaviors where you stop treatment and you give up, and feelings of sadness and hopelessness. And so what we do is we try to look at how that negative thought can really influence our behavior. And so sometimes what people do is they try to push that negative thought and have positive thinking. So I'm going to wake up tomorrow and never have pain again. Unfortunately, when you have a chronic health condition, the pain doesn't necessarily go away. All we can do is manage it. And so what CBT does is help you have more realistic thinking, more balanced thinking, somewhere in the middle, which is based on what your previous experience is. And so it's not that it's always going to go away, but it's that maybe it's really bad right now, but there are some things we could do, perhaps stretches, that can really help subside that pain and make you feel a little bit better. And so let's look at that example of realistic thinking and how we can kind of target that vicious cycle that we saw previously. And so instead of having that negative thought, let's have that balanced thought and say, well, what has worked in the past? And so instead of thinking it's never going to go away, and we're going to have more of a realistic thought about what can we use, what's worked in the past, you're not going to stop treatment. You're going to actually try things that have worked in the past, such as deep breathing or relaxation, or trying some kind of medication that helps you with flare-ups. And so because of that, you're more likely to not feel sad, but more confident and hopeful in your ability to manage that pain and manage some of those symptoms affiliated with that. And so you can see how, challenging some of those thoughts, you can really change how you're feeling and how you're going to be contributing into your world. And so now what I'm going to do is take a little break and let Randy speak a little bit about his own story and share how aging with spinal cord injury has really affected him.
Hello. So first and foremost, whoever's got the hook to get me out of here after while telling my story, if I go on too long, please by all means use it. And also the confusion about my name. I go by Wallace, but my birth name is Randy. And so there's a big story as to why I have to use both right now. But I am currently going. I have been now, it's crazy, 34 years, over 34 years now, since I had my spinal cord injury. Initially, I was a T8 complete spinal cord injury as a result of a motor vehicle accident. And then later on, and I'll go back to this again, as I developed something called syringomyelia, where cysts grow in or around your spinal cord within your spinal column. And as a result, my level of injury is now a 6, went up a couple levels. When I was first injured, I was 20. And how I saw myself and what in terms of my sense of self and what gave me purpose, what gave me identity, was being very active in sports. I rode varsity both Trent and at Brock University. And I was just always on the go, just always moving, always doing something, whether it be cycling, running, doing weights, playing hockey, I was always doing sports. And that's how I saw myself, was as an athlete. When I had the injury, everything changed. In terms of the grieving process, I thought my life was over. I was like, I can't do what I used to be able to do. I've now, completely paralyzed from my chest down, and life was over. And I got really very depressed, really very angry person. And it wasn't until I went to rehab and I was able to basically find a community at the rehab hospital. I was in rehab back in the days when the glory days of rehab, when you were in there was in there for almost 6 months, and you establish friendships and bonds with other people that have experience with you. That really helped a lot in terms of helping me see past but it still did nothing for the anger. And I fortunately ended up getting a counselor while I was at rehab, who, unbeknownst to me at the time, was doing cognitive behavioral therapy. I was seeing her for therapy, but it wasn't until years later when I went to school that I realized, the light bulb went off. So that's what she was using on me. And she really worked at my self-identity and how I could kind of redefine looking at myself, how I could take, it was twofold. It was, one, how could I still be an athlete while in the chair? And two, the things that I've lost, the things that I was grieving, where was a lot of that depression coming from? Where was my anger coming from? And a lot of it was coming from how I thought about myself. So did a lot of work and was able to become very involved in sports and physical activity. And that's, again, what became a very large part of how I defined myself in all aspects of self-identity. So years went on, everything's going cool. Had my daughter, was raising her as a single dad, and life was going great until, boom, I developed syringomyelia. I got the cysts. And I had very much a recurrence of the anger, because I was now paralyzed a little bit higher. I was really fighting with the medical system at the time. And so at that point, I was able to go back and revisit and use some of the techniques that I learned through PT counseling that really helped me work my way through. So that was the one first real major setback in my life in terms of aging. As a result, I now experience a lot more neuropathic pain than what I used to, and also have dysreflexia, which I didn't have when I was currently. So it took time to adjust those changes as I was aging. But skip a little bit further along the path, as my body started to age, I started to develop a lot of things like arthritis, bone spurs in my neck and in my spine. So pain became a real major issue for me. My shoulders started to give out. And I was at that point no longer able now to do the things that I used to do. A lot of the sports, a lot of a lot of the things that made me very independent. And I, again, the anger came back. But what I didn't know is I entered into quite a deep depression. I again, what happened was my self-identity was yet again challenged. And then this time I didn't know how to come back from that. I had a lot of difficulty trying to figure out who I was based on my current abilities. My daughter was older and out of the house, so I didn't have that, being a dad and the purpose that way. My shoulders, it just wasn't safe to participate in the sports anymore because of my shoulders, the big that I had with those. And like I said, it wasn't until the partner I identified and it continued. And so again, what happens? I went back to counseling. That was part of my fallback plan. Is I knew that if things got too bad, I could go back to therapy again. And once again, we worked on that self-identity piece. We worked on the thought challenging. We worked on coming up with goals and finding ways that I could still see myself as an active person, but not in the ways that I had before. So really, cognitive behavioral therapy came to my aid in all three of those instances. And again, a fourth time when a little bit later on, when things started to really degenerate, my shoulders went, I had shoulder surgery. So I guess what I'm saying to you is that there's all kinds of different points in the aging process where things can happen. So as Swati said, you don't have to wait necessarily until you're old to experience these issues. It can happen along the entire life spectrum as your body ages and as things start to change in your body. And some of the changes, can be quite significant, particularly when they challenge your independence. And another thing that I had to do is really learn how to redefine what independence is. And, that even though I couldn't do all the things by myself, which is how I define independence, it is still independent to guide your care and get assistance from people. That was a huge thing that I had to really learn, because I and it happened way earlier than I thought it would. Like I thought, okay, fine, my shoulders and all that stuff, I'm good. I've got until I'm 80 before I have to worry about that kind of stuff. But no, it hit a lot sooner. And so I really give cognitive behavioral therapy. It gave me the tools that I needed to do, and also with the professionals that I went to. And I also am a therapist. So I would say that there would be no need for therapists if there weren't therapists. So I mean, every therapist needs a good therapist. So it really helped me. And also too, it's another indication, even though I knew about cognitive behavioral therapy and I was able to help other people work their way through it, when it comes to dealing with it yourself, sometimes you just get to a point where, and so deep into things, where you need help getting out of that. And as Swati mentioned as well, I mean, there's a lot of misconceptions out there about, identifying having mental health issues, weakness, but it's such a strength to go and to identify that you have some issues and to be able to see. So yeah, that's my story. I tried to keep it within 5 minutes, Julie.
Thanks, Randy. Wallace.
Thanks, Wallace.
Or Randolph.
Thanks, Wallace. Thanks for sharing that. I think that's really going to help everyone kind of understand some of the things that we're going to talk about later on, some of the strategies that we're going to work on in our little one-to-one workshop. And I think kind of what Wallace kind of mentioned about some of the struggles he went through and some of the anger that kind of came through it and the distress, kind of speak to some of the thinking styles, unhelpful thinking styles we get into when we're in those situations. And so I'm just going to take a couple of minutes to kind of go over some of the common ones. So as Wallace mentioned, when you're feeling really down and you're feeling like your self-identity is kind of not the same as you used to have, or maybe you're not able to be an athlete or do the things you used to do, there's some kind of unhelpful thinking styles that are commonly found amongst individuals that are experiencing these types of situations. And one of the ones that we'll talk a little bit about is this all or nothing thinking. And all or nothing thinking is like having black and white thinking, where you only see things from one extreme or the other instead of seeing anything in between. And an example of this is, if I'm not the best at everything that I do, then I'm really worthless. And a lot of us kind of get into that track of thinking that way, especially when we're not able to do the things we used to be really good at. And having that all of nothing thinking really gets in our way of accomplishing some of our goals. Another way thought can be unhelpful, another style is called magnifications and minimizations. And in this type of thinking, what happens is that we tend to magnify like positive attributes of other people, but minimize our own positive attributes. And so an example of this is when, someone else does something really well, you're really quick at, congratulating them, telling them they've done a great job. But when you do the same thing and you do something great, often you might think, oh, well, that doesn't really count. I was just lucky at doing it correctly. Or maybe if someone compliments your work, you might think, oh, they don't really mean it. They're just being polite, and really minimizing, as you can see, other people's compliments to your own work. And then another thinking style that a lot of us kind of tend to have when we're in that distress state is having those shoulds and must statements. And some of those things are, where we put unreasonable demands or pressure on ourselves that aren't really realistic. And a lot of times we wouldn't put that same demand on our family and friends, but we put it on ourselves. And these are really not helpful. So things like, I should be able to do all the chores on time. And sometimes that's not possible with your chronic pain or when there's lots of things going on. So having those should and must statements can really influence your ability to kind of feel good about yourself and accomplish goals. And then the last one that I'm going to talk a little bit about is called personalization. And this is when we tend to kind of blame ourselves for everything that goes wrong. And even when we're not responsible or only partly responsible, we start to kind of, when we're feeling that distress, we start to take on that responsibility of things going wrong instead of really kind of looking at the evidence out there and seeing, perhaps what are some ways that maybe it's not your fault. And so you can see all of these different unhelpful thinking styles can really lead you to experience more distress in your life and not be able to kind of, socially engage or be able to participate as you might be able to. And so the aim of the work in CBT and the module on aging and mental health is really to challenge some of these thinking styles and kind of help you reach some helpful styles. And now what we're going to do is we're going to try to do an activity with everyone and kind of see how we can challenge some thoughts and kind of improve the way we're thinking. And I'm going to pass that on to Randy.
Okay, so this is what we're doing here is there's one of the skills that cognitive behavior therapy presents to people is what's called thought challenging. And basically what this does is it tries to get to the root of where you're thinking or the root of the unhelpful thinking, and to identify it, because like Swati said earlier, thinking positive is something that you can do, and thinking positive definitely has its place, right? Like it can be very valuable, but not when you use it as a band-aid cover over the negative or unhelpful thoughts that you are having. So as Swati said too, what we want to do is look at realistic or more accurate thinking about yourself. So the first step in this is to identify the thought, the unhelpful or unhealthy thought having. So asking yourself questions, what was I thinking? Trying to take a look at what's going through your mind at that time. And this is, again, much easier said than done in many cases, because a lot of our unhelpful thoughts are playing in our head like an automatic loop, like a looping. They're just thoughts that we tell ourselves, and we can really be very, very nasty to ourselves in the things that we think. And it's just that automatic go-to for your brain. So to identify that and attempt to stop it is a task in and of itself. But once you have done that and you're able to tease out and to identify an unhelpful thought, I just realized I was looking at the people, not the camera. The first thing you want to do is then examine that thought. So, and looking for the evidence for this thought, there are a number of different questions that you can ask yourself, such as, is this thought accurate 100% of the time? Is this something that I'm going to worry about weeks, 2 months, 2 years down the road? And one of my favorites is, what would I say to a friend in this same situation? Because we tend to be, as I said, very hard on ourselves, and no way that some of the things that we say to ourselves would we ever say or a loved one. But once you've taken this approach and applied these questions to the thought that you've identified, and you've established that, you know what, the thought I had really isn't accurate, because what I would say to a friend is nowhere close to what I'm saying to myself. But no, this is 100%. Then the next step is to do something helpful. So, how can I make this more realistic and helpful? There's other terms that can be used for the reframing of the thought. And again, what would you tell a friend who had this? So it's a matter of coming up with a replacement thought that is an accurate thought that is going to challenge the original unhelpful. So we have an example that we came up with here. One of the issues that is very prevalent for people after acquiring an injury, and particularly here we're talking about spinal cord injuries, is body image. It slapped me pretty hard, and with aging, I've put on a lot of weight, and again, it doesn't fit with that athlete perspective of myself, so that had to be very challenged. And part of the thoughts I could go, an example of a thought that is related to body image is, I'm afraid to go public because everyone's going to stare at me. Okay, so that is the unhelpful thought that is cycling through the individual's head. So what we want to do then is examine that thought and ask some of those questions that I had earlier, such as, what would you tell a friend? Is this an accurate statement? What do you think in terms of the group? Do you think that this is likely an accurate statement, that everyone's going to be staring at the individual?
I do identify with the thought, but it's never been a reason for me to avoid outdoors. I didn't struggle with it, but it is one of those moments that I do have, and it is not easy to be stared at either, Wallace. So
right. And in those cases, if you're being stared at, why do you think you're being stared at?
now I tell myself it's because I'm so good looking, but earlier it was because earlier I used to think that people would look at me as someone who's incapable of going on independently, and look at her. I don't present a great picture because I used to be with my 2 kids always. So I was very aware. I used to be like, oh, anyone who looks at me right now assumes that I need help, has an opinion on my sense of independence and stuff like that. I just did not like what I thought others thought of me. But then I had a friend said, like, let others worry about what they think of you. You only think of yourself what you think of yourself. So that helped me.
Right. So again, there's a perfect example of what there are some times when challenge these things, and you are going to find that there is evidence that supports the fact or supports part of that thought. So you found evidence that supports part of that thought. Yes, people are going to look at me, however, not for the reason I originally thought.
Wallace,
Yes.
sorry, Shannon just has her hand up, so I will let her ask a question.
Yeah, Shannon.
No, in response to that, sometimes it's children who will stare because they're more
Mhm.
curious. But I find a lot of people will look away from you
Mhm.
because they don't know how to react.
Right.
And I think a lot of it's pity. People look at you and they pity you because you're in your condition. Really.
Okay. And do you think they're staring at you negatively, or is that just perception that's inaccurate?
With sympathy and some negative, yeah.
Yeah, but do you think that's true 100% of the time?
No.
Yeah. So you brought up some great points, Shannon, that again, I think kids are great. Kids are awesome. They'll
Yes.
ask, oh my goodness, they are such clean slates and so innocent in the questions that they will ask. They're because it's untainted, right? So
It's an innocent curiosity.
yeah, absolutely. So, but when it comes to individuals staring at you and them being negative,
Or
Is-
avoiding you.
yeah. And is that something that is inherent with you, or is it their issue?
I believe it's their issues. They probably react with that with anyone in a chair or in that circumstance.
Right,
They're awkward. They feel awkward.
right. So it's not anything that you've done. It's something that they possess in terms of
Yeah, they're just
maybe their
awkward.
own.
They don't
where
know
they
how
need
to
to be.
act.
Yeah. So in both these examples, there was both, yes, people do stare at me, but it's not an inherent problem of mine. It's not something that I possess or a truth about me. It speaks more to the truth about them, right? So with that evidence that, okay, people might stare, but not always in a negative manner and not always the way that I think they might, but even if they do, then that's not my issue. It's somebody else. To do something helpful part of it then would be, how would you change that thought, your thought about people staring at you?
I find a lot of people will rush to help you, will
Mhm.
rush to get a door, or if you're looking at an article of clothing that's out of reach, they'll rush to grab it for you and say, oh, did you want to look at that? Like they
Mhm.
can be very helpful too.
Right.
Like they'll be looking at you to see if there's something you need help with.
So the thought is that some people might be looking at you because they want to be of assistance and they want to help.
Yeah,
So
they're
reframing that initial
anticipating,
thought. Is that
they're anticipating your next need. It doesn't have to be negative.
right? Okay. Phil?
Yeah, I was just going to say, I had one experience that was the most bizarre experience. I had somebody I caught out of peripheral vision and them staring at me. And then the next minute, I seen them running away from me. And then about 30 seconds later, they're crouched down with a camera and they're taking pictures of me. And I was just flabbergasted. I was just like, what is this wrong with this person? You know, I just found it so strange, you know, and I thought, you can't really say take a picture, it lasts longer because that's what they're doing,
That's
you know.
what they're doing.
And yeah, and I'm thinking,
Yeah.
God, that line's not going to work, you know. And it
Oh,
just,
yeah.
yeah. And then you go, well, why are they taking this picture of me? Like, you know, for what reason? You know, if they had wanted my picture, just ask me, you know,
Yeah.
like it's just,
Oh,
but
I'm sure we could all share so many stories of kind of what we would perceive as odd and
yeah.
just sometimes kind of suspicious behavior of other people when they see you in a chair. Absolutely.
It's so hard not to think negative thoughts and about that situation and then start putting it inwards, and then but then you got to think, okay, that you can't take that on. It's their
Okay.
problem, not mine, you know.
That's right. Absolutely. And that is a perfect example of that doing something helpful. right, of thinking that process through. And I know you've done a lot of work on this, Phil, and
Mhm.
you're absolutely right that that, you know, to switch it around and look at it more realistically, right? And it's part of that, as Swati pointed out in the previous slide, is that kind of owning and personalizing and everything being about you, right? And it's not that the issue or the problem could be with the other.
Yeah.
Okay. So what do we have on the next slide? Okay. Let's think of, again, I want to do the same thing, but, oh no, actually, okay. We're skipping ahead. Sorry, I had a brain fart. Now, in addition to when we, as Swati pointed out, that cycle of symptoms, right? There is the thought part, but there's also the behavioral part of it. And one of the strategies in CBT that we use is what's called graded exposure. And this is used to help with avoidance of certain activities. So as we mentioned in the previous example about the being afraid to go out because everybody stares at me, that may result in someone not going out and someone, despite the fact that they have a want or a need to get out and do things, they're going to stay in all the time because they don't want to feel like they are othered or that, you know, there's something wrong with them because of the way public is acting. So what graded exposure is similar to like phobias, like it's used with phobias, like graded exposure, like a step ladder approach to things where you start with the easy task and then you make your way up to the goal that you want. So when you think the steps to this is, first of all, think of it, what is it that you want to do, right? And again, make sure it's safe, realistic, so realistic goals, because you don't want to set yourself up for failure. And also to, depending on what it is, if it's a riskier behavior, you want to check with your doctor. So the next step would be to think of similar activities and rank them from easiest to hardest. So again, that step ladder approach that I mentioned. So break it down into as many steps as you can and start going from the smallest and make your way through. Each time you achieve one of the goals, you go up to the next step and then you go up to the next step. And it's very important that figure out what you can do comfortably and safely. Okay. And again, this is, I was talking to Roberta earlier about shoulder pain, you know, with doing exercises. You got to make sure that we listen to our bodies, and particularly as we're aging and bones are atrophying and muscles are acting up and tendonitis becomes a common problem. And so all of these things come up. And so make sure that you are being safe. So can anybody, and actually,
Wallace, sorry,
Yes.
Roberta has her hand up.
oh yes, Roberta.
You're just
mute.
muted. Yeah, you're muted, Roberta.
When I was 3 weeks into my rehab, my nephew got married and I was determined to go to that wedding. It was my first time out in public since the beginning of the pandemic as well. So I turned up at the wedding, dressed as best I could, hair done as best as I could do it, in a yellow Parkwood wheelchair and with a cervical collar and my head up like this. And I was so shocked to be the object of everybody's curiosity. I don't what I expected. I obviously didn't expect that. So I had ended up putting myself out there, and it has left me with a fair amount of fear of going out, even though I now walk with a walker. no cervical collar. I've gone to the other extreme where I think people don't realize now what I've been through because they don't have visible. I don't have a chair. I don't have, I don't have anything to show the scars. So I put myself out there in the first place, and that really was an eye opener. I went back to Parkwood and cried the whole night. And then when I've seen the wedding pictures, and I looked so ill. I don't know what I was thinking. But now I'm still afraid to go out. I still really, and this is the first time I've said that I'm actually afraid to go out. But that is why I think I'm afraid to go out, is I'm on the other side of that coin.
Sure. Yeah. And well, I mean, that's what a lot of our fears are based out of experience, right? There's something's happened, and something in this case, I mean, that's quite traumatic for you to experience that way. And yeah, of course could be. Oh, got a couple other. Yes, Shannon.
Roberta, I'd like to correct you. I think when you went to that wedding, people were probably extremely proud of you. I know when I had my car accident and I was first injured, I went to my sister's birthday, and for people to see me walk the first time, no matter how I looked, no matter how ill I was, coming out and taking those first steps, even though I had to go back into a wheelchair, it was just the fact that they saw me walk those couple steps. People were in tears. They were so grateful to see me out in public and being a part of life. So I don't think at the wedding, people looked down on you. I think they were proud of you. And that's just my opinion, but I honestly believe that. And even now, if you don't have visible things, like you're not in a chair, people with walkers still obviously have a problem.
That's right.
It could be their spine, it could be anything. So there's an obvious need for you to have a walker. So you don't need to be in a chair to have something wrong with you.
Well, and that's exactly what I have to keep telling myself. I have to remind myself that I have every right to be using this walker, and I have every right to be out there in public. And you're right, Shannon, and my heart knew that the people who knew me at that wedding were so happy to see me and so proud of me. My nephew was, he was just so proud that I had made it to his wedding.
Yeah, that you could go there even.
Yeah.
Hospital.
Yeah.
I'm
But
sorry, I
it's-
just want to interject real quickly. I am getting messages that my internet connection is unstable. So in case the recording stops, it's not intentional. It's just that internet at my end is really shabby right now.
Oh, okay.
I guess the issue is your head and your heart don't always see things
line
the
up.
same way. They don't always,
right.
Your head doesn't listen to your heart, and your heart does not listen.
Yeah.
That's the big problem.
Well, it's interesting. We'll look at the first slide that Swati put up, right? There was the brain and the heart, right? And so there is that you're right, absolutely right. That's the connection. And what you guys were sharing are perfect examples of reframing those thoughts and making them more accurate. And one thing, thank you for bringing it up, and I'll get you 1 second, Phil, is that
no worries.
CBT is a practice-based therapy. So when you said that you have to constantly remind yourself of that, that's all part of the process. Because like I said, you get into that automatic loop of thinking, and it just becomes your go-to. It's like a reflex. So for you, in order for you to change that, is you got to constantly, I like to use the analogy of putting a stick in the spokes, being in the chair. You got to stop that momentum and interject it with something else. And that's what you've done. Phil.
Yeah, Roberta, I was just going to say, listen, I suffered with that year of anxiety about going out. and being seen in public, and I didn't want to be seen by friends and people that I knew in town. And I hid in the house for years, and it was partly because of the fentanyl I was on for pain. That didn't help matters either. But I would encourage you, as we're friends, to get out as much as you can, you know, and it truly, being stuck in a house and four walls is not good for your health, for your mental health, for one thing,
And
you know.
it's,
It
and
just
it's
isn't-
also taking the baby steps to get there, and
Yeah.
starting off small and getting larger, which is something that you could contact us. We can talk more about.
Okay.
Yeah.
So, and so anyway, I wanted, Swati, did you want to get the rest of the slides up, or
I think we may have lost her.
I think we may have lost her.
Oh.
She was
Can I
having
say one more thing?
People from Bell were outside playing with their internet connection earlier, and so anyway, that was actually for this.
Like that. So it's just a matter of getting out there and just accepting it, you know,
Yeah.
and turning it around. Turning it around is in your head is the hardest part.
It's the hard
But
part.
that's
Yeah,
it with the
and that's
CVP.
it.
I encourage everybody to do it. Yep.
It's that
Yeah.
cyclical work. So, and actually, I want to ask you, Roberta, in terms of the graded exposure thing, what would you think in terms of breaking it down into smaller steps? What would some of the smaller steps be that you could do to get you back out?
I think just taking a walk to the mailbox would be the smallest step, because it's a whole fear of people seeing me having to use the walker. It's you know, it's such a complicated feeling. It sounds simple, but it's just a complicated thing to do. And I think that's the first to start going to the mailbox,
Right.
which is a half a block. Well, it's not even half a block. It's about a quarter of a block away. So, but it feels like I jumped in end with the wedding and got out of it. And now I have to start over to get back into the pool.
Back
You know,
into the- Yeah, and that's what you got to, you're absolutely right. And something that you also pointed out is that when you are going through the steps, when through graded exposure, is there are also going to be times where there are going to be thoughts that are there as well. So doing the thought challenging doesn't just happen in isolation as in and of itself, that while you're doing and working on the behavior, there's also the thought process. And as you've explained as well, there's the feelings, there's the fear, right? There's the embarrassment, there's
yeah.
the worry.
Yeah.
There's all of those things that can happen. And again, they all intermingle and all connect to one another. And it's
And there's a whole guilt thing too, because I mean,
Mhm.
I went through a spinal cord injury, but I'm not in a chair. And then I look at what Phil lives with and what you live with, Wallace, and I think to myself, you know, I came out lucky and I shouldn't feel this way. So there's a whole guilt thing about it, you know, it's, yeah. It
I've
just,
talked to many people with incomplete injuries that feel that way.
Mhm.
okay. so
Almost like
that's not
there's a
an
hierarchy of disability,
Yep.
Yeah, so
right?
that's
That-
not
that-
uncommon. Okay, that's
Yeah.
good to know.
Yeah, you're not alone in that. And it's and I actually witnessed when I was in rehab that people were treated differently based on whether or not they, got up and were able to walk the wheelchair. They were treated like, well, what are you whining about? What are you crying about? And I've heard terms like, move past para. Well, you're a paraplegic and you can use your hands. So what do you've got nothing to complain about, right? So it's everybody's journey is their own.
That's right.
And everybody's perception of what is hard and what is easy is their own. And the emotional impact that has, the steps through it you go through for grieving, the time it takes to get through each step is unique to you. And so you're not doing yourself any good by comparing yourself to others. It's just like every spinal cord injury is different, every grieving period is different, and every path and journey through working through that is different.
Okay.
So there are similarities, of course, but, you know, in terms of the lived experience, however, your own personal stuff is your own. Like don't own other people's opinions and other people's,
Yeah.
it's, you experience what you experience because you experience it. And
It's great
Isn't
advice.
it, isn't it the first step is